Okay, we're going to talk about acute coronary syndrome in this section. What that means is myocardial ischemia. The coronary arteries are not adequately perfusing the muscle of the heart itself. Okay, if that is temporary and resolves or comes and goes, it's called angina. If it causes death of the tissue, that's a myocardial infarction or an MI. Okay. We think of MI as a sudden onset, one time, oh no, I'm having a heart attack, but it's actually an evolving status. It gets gradually worse, and someone can be having an MI for several hours to days. The etiology, most commonly, this is caused by a clot. Usually an atherosclerotic plaque. Remember, we talked about atherosclerosis when the blood vessels become stiffened by plaques of cholesterol. Sometimes those can break off and become a clot, become an embolus. Sorry, not become a clot, become an embolus that blocks one of the coronary arteries. It can also be caused by a spasm of the coronary arteries, but most often it's due to an embolus. Manifestation, classic crushing chest pain. Someone clutches their chest, they have crushing chest pain, an elephant sitting on me. That's not always present, especially in women and children. People may feel that pain in their jaw, their left arm, their abdomen, their chest, or in their breast. They may have nausea and vomiting, or they may feel indigestion. Diagnosis, we need to have a high index of suspicion for heart attack. Pretty much with every patient, we always need to be thinking, could this be cardiac? So if we suspect that someone is having a heart attack, what orders do we expect to happen? We're going to see the provider order cardiac enzymes. Troponin is the most specific to cardiac muscle. So instead of, they may order just a troponin. We may see EKG changes. If the ST segment is elevated, that's called a STEMI, ST elevation MI. If it's not, it's called a non-STEMI. But we may see some EKG changes. Usually patients with suspected heart attack or rule out are kept in observation for serial cardiac enzymes and EKGs. Now, if it is diagnosed, they don't keep them around and wait. But we have typically someone comes in with chest pain or with symptoms that are make the provider consider heart attack. They do an EKG, do enzymes, and if it's clear they're having one, then they need to get to a cath lab for care right away. But if it's not clear, if it's a maybe, then they're usually going to be kept in observation for serial enzymes and EKG. Medical management, angina usually responds to nitroglycerin, which is a vasodilator. Nitroglycerin is given sublingual. They can have up to 3 pills and they should be 5 minutes apart. So that nitro is administered, you wait 5 minutes. If it's not improved, you give another one, wait 5 minutes. If it's not improved, give another one, wait 5 minutes. Not improved and it's not angina, they're probably having an MI. Patients who have chronic angina will likely have a prescription for nitro. It's not a med that we just give to everyone. Nitro is going to cause a headache and hypotension because they have it vasodilates. So if they're already hypotensive, nitro is not given. An MI, if someone at home thinks they're having a heart attack, they should chew a 325 milligram aspirin as long as they're not allergic or it's not contraindicated, and call 911 from home. Treatment for an MI in the ER, morphine is the drug of choice for the pain. Morphine not only relieves the pain and anxiety, but it's a vasodilator. Anticoagulants may be given to and try to help prevent further clotting. Vasodilators are given to try to make more room to allow for perfusion. Reperfusion of that cardiac muscle is what actually stops or fixes the heart attack. So the idea is to get blood vessels, to get blood flow back to that part of the muscle before it dies. Thrombolytics are different from anticoagulants. Anticoagulants stop the clotting cascade. Thrombolytics actually break down the clots that are already there. So if a clot is believed to be the cause, there are a lot of criteria that have to be met, but thrombolytics may be given to break down that clot. Now, if we give someone an IV medication that dissolves blood clots, what are the risks? Okay. If they have hit their head, they can have an intracranial bleed. If they've had recent dental work, their gums can bleed. They can have spontaneous bleeding. Their IV site will bleed. So hemorrhage is the risk of giving thrombolytics. Another option, and this one's probably used the most often now, is taking them for a cardiac cath procedure to place stents to reopen that artery. The risk of that and the care for that, remember way back in the first section when we talked about cardiac cath, a cardiac cath can be used to reperfuse the heart. If that's not successful or not possible, they can do bypass surgery to where they remove usually veins from the lower extremities and use those to replace the coronary arteries to allow for perfusion. The other piece of treatment is preventing and managing complications. When that heart muscle is dying, it can cause dysrhythmias, and so the dysrhythmias are most likely to be the immediate cause of death, in particular ventricular ones. So dysrhythmias are managed, and also if enough heart muscle is damaged, they can have heart failure. Sometimes patients who are at risk for MI because they have significant coronary blockages may have either stents or bypass before they have an MI. And if we're not doing those things in an emergency situation with a patient already compromised, the outcomes tend to be better. As a nurse, what is your responsibility? Recognizing the signs that this person may be having a heart attack. ER nurses, if they have a patient come in with chest pain or suspected heart attack, they're going to have a protocol of orders to get started on right away. If you're working the floor or you're working in home health, you're not going to have those orders already. So you need to know what you're looking at and how to access emergency care. Nursing care, we need to be teaching people the signs of a heart attack. What does a heart attack look like? In particular, people who might have unusual or different symptoms. We also want to teach people, if they think they're having a heart attack, don't drive to the emergency room, because a life-threatening dysrhythmia can occur. Then they have a car wreck and a heart attack. So if someone goes into VFib while they're driving, they're not going to be conscious for very long. Now we've got a car wreck and a heart attack. So we want to teach people, if they suspect they're having a heart attack, to take aspirin and call 911. We'll be assisting with screening patients for whatever reperfusion options are available and prepping the patient for that. In a rural facility, that's going to involve maybe starting some meds and transferring that patient quickly to a location that has a cath lab. If we're in a cath lab, it's going to be post-procedure and post-op care. If they have surgery, then we're looking at the nurses that working in the coronary care unit and that post-op care. And then after their recovery from that heart attack, that patient should be in cardiac rehab to try to prevent future occurrences. Cardiac rehab would be an example of tertiary prevention. Do y'all remember way back last semester when we talked about primary, secondary, and tertiary prevention? Primary prevention for heart attack is managing cholesterol, managing risk factors, right? Secondary prevention is teaching people how to recognize, and professionals recognizing, hey, this person might be having a heart attack. Okay. Tertiary prevention is helping them to recover from that heart attack and prevent recurrence. All right, in the next section, we're going to talk about pulmonary hypertension.